you so much. All right, first I want to make sure that you can see my screen that I'm sharing. All right, and I am going to put some things in the chat. Let's see. All right. Are you all able to see them? So there are 3 attachments. What we did, Abby and Lorena were kind enough to translate the presentation that I am sharing with you right now in Spanish, so that is attached. Also, if we were meeting in person, we typically share a handout, a program, so that is also attached in English and Spanish as well. All right, so thank you so much for allowing us to present. I am Alecia. All right, so we'll get started. So I am the co-principal investigator for the Shaw site, and I'm mainly responsible for the dissemination component of the Shaw site. And I've been here a couple of years, but I've been in computing information systems for about 35 years. And I began my academic career at North Carolina State University and so on and so on. And it's been a long journey, but I was introduced into public health a couple of years ago by Dr. Dorothy C. Brown. She will be joining us a little bit later today. So if you pay attention, if you look at our program, you'll see our agenda today. And you'll see that she is supposed to follow after me, but we'll get out of orders just a little bit and give her a chance to get here. So we'll move on to allow Lorena and Abby to do their piece. All right. So first I want to introduce Lorena Gonzalez. She is a senior majoring in psychology with a minor in business at Shaw University. Originally from Spain, she is passionate about both her academic studies and sports. Alongside her coursework, she plays soccer at the university level and has been actively involved in research for over 2 years. She is driven by the desire to combine her academic interests with her love for sports and personal development. And while I'm doing that, I want to introduce also Avril Malilo. All right, so Avril is 21 years old and she is from Caracas, Venezuela. She is currently studying at Shaw University and majoring in mass communications with a minor in business management. She came to the United States at the age of 15 to pursue her dream of playing soccer. She completed 3 years of high school at Monteverde Academy and currently plays for the Shaw University soccer team. Additionally, she has been working as a researcher at Shaw University for a year and a half. All right. Without further ado, Lorena, take it away.
Hola a todos, mi nombre es Lorena González y soy una de las estudiantes asistentes de este proyecto. Soy estudiante internacional en la Universidad Shaw y vengo de España. Hoy quiero compartir con ustedes cómo el COVID-19 me afectó personalmente y cómo se relacionaron el trabajo de investigación que hemos realizado con cómo la pandemia impactó a las minorías. A través de este proyecto, espero que podamos ayudar a los líderes y organizaciones a apoyar mejor a las personas más afectadas, en caso de algo similar que vuelva a ocurrir en el futuro. He estado trabajando en este proyecto durante casi 2 años, desde el principio de este proyecto, y ha sido la experiencia más enriquecedora de mi vida. Aunque la pandemia afectó a todo el mundo, sabemos que los grupos minoritarios fueron los más vulnerables. Este estudio, basado en encuestas y entrevistas a una amplia diversidad de personas, tiene como objetivo entender cómo los diferentes grupos fueron impactados de manera desigual y cómo podemos mejorar las respuestas a futuras crisis. Para mí, la pandemia comenzó en un momento muy complicado. En ese entonces yo estaba en España, todavía cursando la secundaria. Cuando el COVID-19 comenzó, todo cambió. Las clases pasaron a ser online y la vida se volvió muy aislada. Durante 3 meses no pudimos salir de casa, solo para hacer la compra y tirar a la basura. Y si te veían fuera de casa, te multaban. Unas medidas realmente muy duras. Aunque estaba con mi familia, me sentía muy sola y las incertidumbres sobre el futuro me afectó profundamente. La pandemia me obligó a adaptarme a una nueva realidad que fue difícil de enfrentar. Después de un tiempo, decidí venir a Estados Unidos para estudiar y jugar al fútbol en la universidad. Sin embargo, mi llegada a este nuevo país fue marcada por los efectos del post-COVID. La vida universitaria no fue como lo imaginaba. La socialización era mucho más difícil, ya que las interacciones en persona eran limitadas y no fue hasta que comenzamos los entrenamientos que realmente pude conectarme con mis compañeras. Más tarde, durante las vacaciones de Navidad, regresé a España, donde la situación del COVID-19 seguía siendo muy difícil. Fue entonces cuando mi abuela falleció. Debido a las estrictas restricciones de la pandemia, no pude estar con ella ni despedirme. Las reglas eran tan severas que no pude viajar a su lado para brindarle apoyo, y además los servicios sanitarios estaban desbordados, lo que hizo que ella no recibiera la atención adecuada. Fue un golpe muy duro para mí y para mi familia, ya que la situación me hizo sentir aún más importante y alejada de lo que estaba ocurriendo. A todo esto se sumó la difícil situación económica de mi familia. Mis padres también vivieron momentos complicados durante la pandemia debido a la pérdida de trabajo y las restricciones. Esto agravó aún más el desafío de adaptarme a la vida universitaria en Estados Unidos y a un entorno nuevo, haciendo que me sintiera aún peor sin saber cómo ayudar. Es por todo esto que este proyecto es tan relevante y me siento tan motivada. Este proyecto no solo se trata de recolectar datos, sino también de escuchar las historias y darles voz. Al estudiar cómo el COVID-19 afectó a las minorías, podemos identificar las barreras y los desafíos que enfrentaron comunidades como la latina y la afroamericana. Sabemos que los grupos más vulnerables fueron los que más sufrieron, con dificultades para acceder a recursos, un mayor impacto económico y social y barreras para recibir el apoyo necesario. Nuestro objetivo es intentar de que en el futuro las comunidades más afectadas puedan contar con el respaldo adecuado y que los líderes y organizaciones lo puedan hacer mejor. Quiero agradecer especialmente a Dr. Brown y a Dr. Georgie por su apoyo durante este proceso. Sin su guía y sin su conocimiento no habría sido posible. También agradezco a todos ustedes por darme la oportunidad de compartir mi historia. Espero que nuestra investigación pueda hacer una diferencia real en el futuro, especialmente para las determinadas comunidades. Muchas gracias. Y ahora os dejo con mi compañera Abril Melillo.
Hola, mi nombre es Abril Melillo y les quiero compartir un poco también sobre cómo el COVID-19 impactó mi vida y también cómo este proyecto me ha ayudado a escuchar las historias de otras personas, entendiendo los grandes cambios que que la pandemia trajo, tanto a nivel económico como de salud y en el estilo de vida de muchos, ya que cada situación fue diferente. Pero cuando el COVID empezó, yo tenía 15 años y estudiaba en un colegio, era internado en Montverde, que vivíamos en el campus porque eran personas internacionales. Y inicialmente nos dijeron que tendríamos 2 semanas de vacaciones y nada más. Pero eso se convirtió en medio año. Estuve medio año viviendo con mi tío, ya que no me iba a devolver a mi país, porque era muy costoso ir 2 semanas a mi país. Y terminé viviendo con mi tío medio año y un poco más. Y estuve un año sin ver a mi familia. Y tuve que terminar el año escolar en línea, como muchos, y trabajos. Y cuando regresé al año siguiente, aunque las clases eran presenciales, todo se sentía muy extraño, con los tapabocas, pruebas de COVID cada semana o cada 4 días, o nos aislaban algunos estudiantes y había muchas restricciones. El COVID-19 cambió la vida de muchos y se llevó a muchas personas queridas. En mi caso, perdí a mi padrino y alguien muy importante en mi vida. Y esta pérdida, al igual que otras historias que he escuchado, me hizo reflexionar profundamente sobre lo frágil que puede ser la vida y la importancia de apoyar a quienes nos rodean. A través de este proyecto he crecido mucho como persona, he aprendido a escuchar con empatía y a valorar las experiencias únicas de cada individuo, ya que muchas personas que participaron en nuestras encuestas compartieron cómo perdieron sus trabajos, hogares y lamentablemente incluso familiares, ya que cada historia es un recordatorio de que aunque la pandemia afectó a todos, no lo hizo de la misma manera y para algunas personas las consecuencias fueron devastadoras. Este proyecto no solo se trata de recoger datos, sino de entender cómo se siente cada persona y hacemos encuestas y preguntas para profundizar en lo que han vivido y cómo se han adaptado. También nos enfocamos en buscar formas concretas de ayudar y crear un impacto positivo en nuestras comunidades. Quiero destacar que nunca es importante y que nunca es demasiado tarde para entender una mano, para escuchar o para encontrar maneras de marcar una diferencia en la vida de alguien. Y es por eso que estos proyectos son tan valiosos, porque nos permiten acercarnos más a las personas y comprenderlas, y sobre todo actuar si podemos y ayudar a los demás. Y bueno, muchas gracias por su tiempo y por permitirme compartir mi experiencia. Si tienen alguna pregunta o comentario, estaré encantada de responder. Gracias. Y pasaré a Dr. Georgie otra vez. Muchas gracias.
Thank you, Abby and Lorena. Aren't they? So because we got out of order, I forgot to mention just a little bit about our project. So we are part of an HBCU, a historically Black college and university health equity data consortium. And it is a model that emphasizes equitable approaches to community engagement via the development of minority serving institution and infrastructures. And so we are funded by the North Carolina Department of Health and Human Services, and the headquarters for this particular consortium is on the campus of North Carolina A&T State University. The additional universities and colleges that are participating in this consortium are listed near the back of your program. And in this project, the current work focuses on the expansion of COVID-19 data surveillance in North Carolina's 6 Medicaid regions. And by doing so, the state was able to gain a more comprehensive, or at least that was the hope, understanding of how COVID-19 impacted social, health, and economic outcomes. And in this project, we work together to fill vital data gaps related to COVID-19 impacts across various economic and disability measures. Our primary investigator is Dr. Dorothy Brown, and I see that unfortunately she had another engagement and was hoping to get here. So we'll keep moving. We won't prolong you, but she is our primary investigator. All right, so next we're going to have our statistician and data analyst, Mr. Melvin Jackson, present our findings. Melvin is known as the community statistician in that he takes complex statistical data and analysis and presents it in an understandable fashion to individuals who often find statistics and data analysis confusing. He uses the data to tell a story so that it excites the audiences, especially those that don't come from data. His ability and love for sharing data with community audiences is one of the reasons he co-founded the Prime Collective, LLC, a group of community experts who consults and partners with academic and community-based organizations. Melvin not only is involved in the Shaw Health Equity Data Consortium, he is a consultant or has been a consultant with numerous groups, including the Southeast Raleigh Promise Initiative in the regions of solutions, tools, skills with racial equity lens, strengthening the Black Family Incorporated and the University of North Carolina and the Campus and Community Partnerships for Health. Without further ado, I'm going to present to you Melvin Jackson.
Thank you, Alecia, and you gave me a great introduction. I couldn't do that well myself, and I'm finding it a pleasure to come before you to talk about this particular project. And as Alecia indicated, I want to make sure what I say is understood, so at any point in time that I need to stop, slow down, reiterate something, I'm not really able to monitor the chat. But if someone just stops me and there's a question, I'd be willing to answer it. This portion of the program is probably going to take us about 20 minutes, leaving us probably about 5 or so minutes to answer questions. I'm going to focus on our methods and approach. And one of the things that if Dr. Brown was here, she would really say that we're building from an initial pilot work that Shaw University conducted in Durham, North Carolina. And again, she approached the state with the intention and the idea that there are individuals that are not being reached in the process, the normal process of collecting data and information. As if you recall, when COVID-19 first hit, there was not even a good method of describing the impact of the disease or the virus by race, and that became a big problem. So the community had to step in. When I say community, you, we, and everybody else stepped in to try to fill some of the gaps. Next slide. Alecia sort of went through this slide here, and I'm not going to really go through it again, but this is just the infrastructure of how we've been set up. And you see on the right side, the administrative hub, and as she indicated, there are actually 2 phases to the work, but I'll talk a lot about that later. We had a data collection team out of an ancillary member out of UNC and a number of partners. Next slide. Okay. Our goal, and again, as indicated, is to understand how households in North Carolina were impacted by COVID-19. And we discussed the funders, but these 4 windows we've got set up here pretty much is a great summary of where we are. I'm gonna start at the end and come back. We're currently in the process of organizing data dissemination events, which this is one of them, and collecting feedback to measure the effectiveness and obtain information from you as an audience about the information that you're receiving. And you will, and we'll talk about it later, you will be getting a link to a feedback form. Going to the front again, we've collected over 15,000 surveys of participants assessing their COVID-19 impact. Our goal was to look at it, how is it impacting persons around their wealth or lack thereof as a result, and disability status. We analyze and disseminate the survey findings and the results for each of the 6 Medicaid regions, and we use the partnerships with community-based organizations such as this and faith-based organizations, and develop community advisory boards to help inform how we collected the information and did the research. Next slide. Next slide. Okay, so these three big boxes here, our focus and our goal was to engage communities around North Carolina through direct outreach from mail, phone, and in-person events. We used two different ways of collecting the data. We had statistical sampling, where essentially many of you know about the census. Basically, we identified homes through a sampling process, households through a sampling process, and we use a randomized system of collecting the data. I always think of randomizing from a situation where you put names in a hat, shake the hat up, shake it up very well so there's no bias in how it's set in the box, and then you start pulling names out of the hat. But the direct outreach was through community organizations and community events. We also used web-based and paper-based surveys, specifically when we did the outreach in our community events. Some individuals were more used to doing things on the web and on a tablet, but others preferred a paper-based survey. So we provided those surveys that individuals could fill out. If they needed support, we would have staff members and research assistants to fill it out, get it in both English and in Spanish. Next slide. To give some considerations, and I'm going to tell you there are two slides here, and I'm going to back up and come back to the second slide. And some of the data considerations for dissemination or for these presentations, we wanted to explore new community engagement data collection methods. And when I say new, that's new to some people, but it may not be new to the people sitting in this room, because we know that it's important to do community engagement and going out into the community and collect the data where people are versus necessarily doing it online or by phone. The other, I mean, I'll let you read through those bullets, but the other ones that I really want to address is our approach included some biases that influence who was able to respond. Again, there were some individuals that may not have had access to a computer or a smartphone to fill out the form. And also, if one was able to do it using the randomized system or the randomized process, you would have what I would call a much more robust database. So to work around that, what we were able to do was to do these community events and address some of those biases by identifying more diverse responses, representatives of responses. And again, that is taking the process to the community, to the Latinx community, to churches, wherever we thought we were able to, even to schools, where we were able to collect the data. And also, in spite of these statistical biases, we feel that we do have a robust database. One of the things I will say about the process that we use and not having it all from a randomized system is that it impacts who you can make general inferences or general statements about. We cannot make statements about everybody in the state of North Carolina because we didn't have that process in place. But as long as we recognize that we can make statements based on the people we collected the data from, then we're still in a good place. Next slide. Okay, I'm gonna go to this one and I'll come back to the next slide. So as I said, we collected about 15,000 forms, but in actuality, we had about 11,500 that qualified to be involved in this analysis. Some were duplicates, because if you think about it, you're collecting across households. We wanted one person in each household. We did multiple events, so you may have gotten multiple people in the same household. So we tried to go through and eliminate data that may have been duplicate or may have been false data that we didn't want in the data set. So if you look at the little map there, we've got 6 regions, and I'll continue to come back to those regions. So if you can sort of take a picture in your head, because you always may not see this map, but region 1 starts in the west, and that sounds like where a lot of people are focusing their time around what's happening in terms of the hurricane and relief. And we've got region 2, region 3. Our particular region is region 4. So those 2 dots, one represents Shaw University, other represents North Carolina Central, but essentially one represents Raleigh, the other represents Durham. The next region is region 5, which is down sort of southeast Fayetteville, Sand Hill area, and region 6 is those west counties. And based on these data, you see that 49 out of 100 were Black, 33 out of 100 were white, 9 out of 100 were Hispanic or Latinx, and about 4 out of 100 were American Indian. And these numbers are based on where we were able to go and collect the data. And as you see, individuals reach represents a much more diverse group than used traditionally in surveys, in terms of sometimes the last 2 numbers tend to be smaller, and that middle number, 33, tends to be maybe 60% of the data. So we tried to make sure that we were trying to get a more diverse community. Next slide. I want to step back and talk a little bit more about our methods. To be involved in the survey, you needed to be 18 years or older. And especially, and this 14 comes from Region 4. Region 4 made up 14 counties. So you needed to have lived in those 14 counties to be eligible. I talked about survey aimed on community participation, using community-based and faith-based organization, as well as the Community Advisory Board. And I talked about the probability sample, which is the household sample, and the convenience sample is essentially talking about samples that we collected by going to community events and collecting data in those fronts. We use a number of different online methods. We use Qualtrics, which is a data collection tool similar to, I would say, a spreadsheet from Excel. We use the call center as well as the community events and other venues. Participants were offered an incentive of $30 for participation, and we always believe that it's important, whether they accept it or not, that you compensate individuals for their time. Next slide. Okay, now I'm going to shift back again to the data collection process. This is phase 1. Remember, phase 1 represented region 2, region 3, and region 5. No, region 6, my fault, region 6. So that was the first group that we conducted the survey between February 2023, July 2023. And there were 3,300 eligible participants that responded. There were 52% were Black, 34% were white, and about 6% were Hispanic and Latinx. And you notice that number's a little smaller, and sort of is based on, if you look at region 3, 2, 3, and 6. Some of that is about distribution, but we really learned, because this was a smaller sample, data collection sample than we're going to see in region 1. But so we learned from the pilot. We used it in phase 1, and next slide, and then we moved it to phase 2. Phase 2 represented the Medicaid regions 1, 4, and 5. And as I said, when I say we, I'm really talking about the work that we've done. There may be people on this Zoom that may be in some of those other areas, but as far as we're going to focus on phase 4 when we get down further. So that data collection period lasted between 2023, November, and February 2024. So you see, we were rolling out of the emergency, I would say, of COVID-19. But both of these phases occurred when we say we were sort of at the end of the real pandemic in the United States. A total of 8,000 and a quarter so responded. And again, we built on phase one. 48 out of 100 were Black, 33 out of 100 were white, and this number bumped up a little bit. 10% were Hispanic or Latinx, and American Indian, 5 out of 100. I'll slow down. Are there any questions before I move forward? Okay, next slide. Okay, now I'm going to try to, as much as I can, tease out the data that represents the Hispanic and Latinx. And again, I should have said that before, we classified in these data Hispanic and Latinx as anybody that classified themselves as Hispanic Latinx, regardless of what other race they may or ethnicity they assign themselves to. So they sort of come down into 3 categories: anybody or any race that fall into the Hispanic Latinx or ethnicity, and then you have Black non-Hispanic and white non-Hispanic. But again, we're going to focus pretty much on the data that's represented in that red box. Overall, they're about 9%. And again, this is sort of repeating what I said in the other slides, but I break it down a little further. About 6% were in phase one and about 10% in phase two. But if you look a little bit closer in terms of the regions themselves, region one, we had the highest percentage. Region 4 was the next, and region 3 falls right behind that. So those are the regions where we have the highest percentage of Hispanic Latinx. Next slide. Okay, this slide gives us an idea overall in terms of who responded. I gave you those numbers before in terms of the percentages by race. This is really just looking at the households. What percentage of the individuals, let's look at the top line overall, out of the 11,500, what percentage of them had no one reporting as having a diagnosis of COVID-19? In the third column, you see the percentage that say they'd had the diagnosis. And pretty much, and it's pretty consistent, it varies within the regions and within the phases, but 63% on average reported as being having a diagnosis in the household. These are not individuals. These are the number of households that identified as or responded as having a diagnosis of COVID-19. If you look down further, again, you look at on average is 63, and I'm going to go, put some words behind some of these. On average is 63, but if you look at region 1, again, region 4, these are regions that are above, that represented above the average percentage. And you have region 2, region 3 were ones that were below. The others were pretty much right on par with the overall data. Next slide. Okay, here I'm breaking it down or displaying it by Hispanic, by region, but also by Hispanic origin or race. Again, overall, it shows up in the Hispanic community as about 67, and you can look down further. Phase 2 was right on, phase 1 and 2 were phase 2 was right on, right on average. But again, I like to say numbers count. So that there were 8,000 people in that phase, so they would sort of dominate the percentage overall. But if you look down in the regions, they break down pretty similar in that regions 3 and region 4 had the highest percentage that had diagnosis of COVID-19. Next slide. Okay, so again, this is looking at region 4. This is looking at region 4. I gave you phase the different stages, but again, you see about 10% Hispanic and Latinx in this particular region were reported. Next slide. I'm not going to go through this slide, but it shows you similar information as it relates to the region 4, which is the last column. Next slide. But if you look at the Hispanic community, you see that those diagnoses, again, these are numbers that we've talked about before, the 69%, and the ones that the severity, I'm going to talk about that in words in the next slide. So you can take a look at it, and we'll move on to the next slide. Okay, here you see about 69% of individuals in the household reported having COVID-19. Again, these are very similar numbers. You're looking at severity, about 46%, which is slightly lower than the overall average that had household with severe illness. Next slide. I'm trying to speed up a little bit, and that I'm running a little long. 81% reported hospitalizations, and 32%, or 30, it's 32, but it's 3 out of 100 represented deaths in the community, and that was slightly higher than the overall. You see the 7 and the 9. And when you look at symptoms over 4 weeks, 11 out of 100 reported those symptoms. So that number was also high compared to overall. Next slide. This is a heat map, and I'm going to go a little deeper into the heat map, but I'm going to pull out some top numbers. And the thing about the heat map is that the redder the box, the greater the percentages. The next slide, I'm going to talk a little bit more about it, but I just wanted you to show you why I'm focusing on that top group. Next slide. So if you look at it in terms of the most common, a snapshot of the most common, you see that when you look at the Latin and Hispanic, the Hispanic and Latinx communities, the top number was loss of income, and the next one was change of employment. I'll go to the next slide and get a little deeper into that. And this is overall. Next slide. Okay, the thing to highlight again, we talked about loss of incomes, but down in the bottom, the Hispanic respondents reported a higher percentage of loss of income and changes of employment. So those are the two big bucket items that stood out in terms of the greater impact of COVID-19 in the Hispanic Latinx community. Next slide. This holds true. This is region 4. Again, you could take a look at that. I'm gonna move to the next slide. And again, I'm highlighting those heat bumps, I'll call them. And in the next slide, I'll put some words to it. Okay, here, those first 3 items, they tend to be they were a little bit lower in those areas when it came to feeling more stressed, worried about health of family members. But again, the high piece was the loss of income. There were 38% compared to region 4 overall of 26%. Next slide. Okay, this is saying pretty much a similar thing, that loss of income and change of employment. And if you think about this, these are the things that were really impacting specifically in the Hispanic Latinx community, but overall, these are very important issues. Next slide. Okay, I'm gonna hit some highlights in these slides here. These are key associations across risk factors. Hispanic and Latinx of all races were 2.37 times more likely than whites to have a negative or zero wealth. And when we talk about wealth, we're not, before I was talking about income, people having loss of income, but this is talking about wealth. This is including any assets you may have, any, bank account, other things that may connect. And in reality, if you think about it, there are a lot of individuals that have a degree of wealth that were not quite as impacted by COVID-19 as these two communities, the Latinx, Hispanic Latinx and the non-Hispanic Black. But if you look at households with older adults, they were 3.39% more likely to have someone with a disability. I'm not going to get into the other slides. I'm going to move to the next one. I'm going to try to hit the red spots right now. When you think about it, in region 4, households with someone with disability, 1.48% more likely to experience a severe illness. They were also households with children were 1.33% more likely to experience COVID-19 in the household. The one that hits me the most is households having to miss work due to the lack of child care, were 3 1/3 times more likely to experience COVID-19 within their households compared to those that did not have to stay home because of the missing work because of child care. And again, that to me, that it may take a minute to sit with you, but that's a very important item that we want to highlight. Next slide. Okay, that covers what I needed to talk about, and I want to ask you before I approach these questions here. Are there any questions, anything that stood out to you that that was familiar first or surprising? And so if we go through these questions, does these findings reflect what you've seen in your communities? And if not,